Professor Young-Wei Chi from University of California, France, dear friends of many of us, is usually saying good morning, good afternoon, good evening, based from where you are. I'm Sergio Gianesini from the University of Ferrara and the Wind Foundation. I'm simply hosting technically this moment. I will be giving the mic to Professor Mo in a second for the initial greeting as well to this international session of the Japanese Society of Phlebology, joined with the Latin America Venous Forum and the Panamerican Society of Phlebology-Lymphology. Professor Mo, would you like to say a word of welcoming?
Yes, welcome to Japanese Society of Phlebology International Session. And we'd like to talk, we are very happy to have you, and also we'd like to express special thanks to the organizer and the Win-Win Foundation and JSP 40, and also related person. And we will present a part of a Japanese society, but Japanese venous study. And also we are very happy to hear every papers from all over the world. Thank you.
Thank you so much, Professor Mo, and thank you so much to all the leaders involved in this organization and the organization involved indeed with the scientific societies, in specific the Latin America Venous Forum with Professor Simkin and Bottini, the Panamerican Society of Phlebology-Lymphology with Professor Ernesto Intriago, the French Society of Phlebology with Professor Matthew Josnen, but of course, first of all the boards of the Japanese Society and all the colleagues from the Japanese Society. We have a welcoming from Professor Takayiro Imai. So Takayiro.
Hi, thank you for today. I'm Takahiro Imai, the chairperson of the first session. Thank you for joining us today.
Thank you, Takayiro. We move forward with the greeting of Professor Tomohiro Ogawa.
Good afternoon, members and guests. On behalf of Japanese Society of Phlebology, welcome and thank you for participating in this international session. Especially, I greatly appreciate the Win-Win Foundation, Latin America Venous Forum, and Pan-American Venous Lymphatic Society to collaborate for organizing this session. This annual international session, together with the Congress of Japanese Society of Phlebology, started from 3 years ago, mainly collaborate with the Win-Win Foundation, Professor Gianesini, for discussing about research and clinical study about venous and lymphatic disease with international lecture and excellent Japanese papers. This session becomes sophisticated year by year. This year, although coronavirus infection spread all over the world, disrupt face-to-face contact, we could also discuss with a member of Latin American Venous Forum, Pan-American Venous Lymphatic Society, UIP, and Win-Win member online today. We like to contribute to communicate the International Phlebological Society for the development both our and international society. On the era of the endovenous treatment for venous disease, even Japan, we face over-operation for mild varicose pain or non-varicose varicose pain at a few medical institutions, as same as the other countries. We are taking a measure for the inappropriate use of endovenous ablation. In regard with the good news, we could install the thermal non-tumescent ablation, cyanoacrylate venous embolization for the primary varicose pain, and compression therapy for venous ulcer with reimbursement of Japanese health insurance. And now we are working for the approval of venous stenting for occlusion of iliofemoral vein. Under the prevalence of coronavirus infection, many Japanese medical institutions engage in the treatment of coronavirus infection. In some of clinical cases, venous thromboembolism induced by this infection is new interesting topics. I hope this session polish your knowledge and make you realize new aspects of phlebological subject. Please enjoy the meeting. Thank you.
And we thank you, Dr. Ogawa, once again, and we welcome the greetings of Dr. Carlos Simkin from Latin America.
Hello, my friends, dear colleagues. Welcome. I am very glad to be here virtually, but very close of all of you. This is our session, our joint session from Latin America. My name is Carlos Simkin. I'm the president of the Latin American Venous Forum, and this joint session is going to be fantastic. We're going to have another society from Latin America, the Panamerican Society of Phlebology, and of course the Bwin Foundation supporting us, celebrating your 14th anniversary of the Japanese Society of Phlebology. I hope you will join very, very much this session, and thank you very much for this joint session to share knowledge in phlebology and lymphology. Greetings, bye-bye.
We deeply thank you, Professor Simkin, and we now have the greetings of Professor Bottini from University of Buenos Aires.
Dear friends from Japan and Latin America. First of all, I want to thank the authorities of the event for opening an enormous window towards Latin America. As you can see, the most representative society in Latin America are included in the historical project, being the first time that a link of this characteristic has been generated. It is also an honor for me to belong to this working group of the Bwin Foundation, capable of building an extensive scientific and educational bridge linking such distant region. It will undoubtedly be the first of many activities that will go through in the future. I want to invite you to be present at our Buenos Aires 2021 Congress, where Latin American societies and many others from the world will participate with a prominent space for the host of this event. We are waiting for you with a tango, meat, and a good wine to toast together when this difficult moment has been there. Thank you.
And as a last greeting, we have also Professor Intriago from the Panamerican Society of Phlebology-Lymphology.
Hi, I am Dr. Ernesto Intriago, President of the Panamerican Society of Phlebology and Lymphology. Thanks to Dr. Takashi Yamaki for the invitation to participate in the magnificent Congress of the Japanese Society of Phlebology. Hoping to meet you again in our next event. We will be kindly waiting for you with our open arms in Guayaquil, Ecuador, in our 19th Pan American Congress in 2022, united by science, shortening distances. Thank you.
And flying away from Latin America, now we fly to Europe for a brief greeting from the French Society of Phlebology.
Good morning to all. My name is Mathieu Josselin. I am the current president of the French Society of Phlebology. I am a vascular physician in the west of France. First of all, I would like to tell you how honored I am to be with you today, to have been invited as chairman to your international congress, whose program and speakers make it a reference congress whose reputation is very well established. I would like to thank organizer of this congress for their invitation and Dr. Sergio Giannettini for allowing us to meet. The French Society of Phlebology is organizing its national congress next December in Paris. We are, of course, in the uncertainty of maintaining it in person and are working on a hybrid solution. However, I would like to invite members of the Japanese Society of Phlebology to officially attend our congress on behalf of the French Society of Phlebology. I think we can look forward to the years to come and envisage a joint session between our two countries and hopefully in a real life. I wish you an excellent Congress.
We deeply thanks Professor Josnen, and now we start with the scientific session and with Professor Mo lecture on appropriate use of endovenous ablation for varicose veins.
Title of my talk is Appropriate Use of Endovenous Ablation for Varicose Vein, lesson from Japan. Overuse of ETA is a growing problem, such as varicose vein without symptom, segmental reflux or no reflux, or routine simultaneous treatment of the both leg. Those are performed by the doctor who are not well educated and possibly motivated with financial reason. The number of the venous surgery is rapidly growing, especially ETA. Japan has a national public health insurance system for whole people, mainly supported by tax. ETA is covered since 2011. This lady presented with right leg pain, and a duplex scan demonstrates right short surface vein incompetence. ETA was performed by the other clinic. Surprisingly, ETA is performed bilateral GSP, but not right SSV. We suspect this clinic always performed routine bilateral ETA with a poor ability of diagnosis. These are actions of JSP against inappropriate use of endovenous ablation. Because of that, we have a lawsuit of the deformation of the character, resulting in the loss of JSP site. We sent a alert in 2019 and the declaration against inappropriate use. This declaration is supported by multiple medical society. We published clinical practice guideline for ETA for varicose vein in 2019. We also published supplemental guideline about overuse for the inappropriate indication. Here is the definition of the inappropriate use of ETA for varicose vein. National health insurance system should not cover those ETA. ETA for normal vein or venous dilation without valvular insufficiency is inappropriate. Part of patient with segmental valvular insufficiency of saphenous vein is not good indication of the ETA. Here is an example of that because 30 to 40% of patients have venous reflux in general population without chronic venous insufficiency. Varicose veins without stasis symptom is not the indication of ETA. We have to be cautious. Symptoms of varicose vein of the lower extremity are not disease specific and often caused by the other disease. And from the evidence, previous study of ETA were performed in symptomatic varicose vein patient. ETA to prevent worsening of varicose vein or pulmonary embolism in the future is inappropriate. Natural history demonstrates only limited cases require surgical treatment, and favorable prognosis with treatment after appearance of symptom is demonstrated. There is no evidence for benefit for prevention of the DVT or PE. Appropriate use criteria is also published in United States. Here is a lesson from Japan. Even with the effort to diminish overuse of the ETA by JSP and the related vascular society, Ministry of Health and Labor of Japan decided about 30% reduction of the reimbursement or ETA. Government asked to follow appropriate use criteria by JSP for reimbursement. Here is action by academic society, education of physician, education of the patient, and the restriction of the certification for ETA. We ask a pledge for inappropriate use. Violation cause loss of the certification. Reimbursement is restricted based on the JSP appropriate use criteria. and the duplex image is a requirement for reimbursement. Overuse of ETA for wrong indication is against ethics. It results in loss of the credibility and the destruction of the venous healthcare system and the academic community. Thank you very much.
And with this, we deeply congratulate Professor Mo for this brilliant lecture, also for the moral aspect of that. So my question to him is basically about the United States attitude, for example, of having graduated compression stockings used for some months before allowing reimbursement. Would you think that this is something that could help increasing the awareness also of the health authorities about proper treatment, same with venous active drugs? And this is his answer. Professor Mo, would you like to go live or should I play the video?
Yes, the record is fine. Yeah.
Okay.
Yes. Thank you for question, Sergio. Yes, to try on stocking and observing improvement of symptom is a good way to rule out leg symptom by another pathology other than varicose vein. I always ask try on stocking before the surgery. Talking about the drug, so far venous active drug is not approved in Japan. It is difficult to try drug now. Thank you for the question.
And we thank you, Professor Mo, and we congratulate him. And we move to Professor Young-Wei Chi from University of California, Davis, talking about compression in a thrombotic COVID time.
Thank you very much.
Thanks to you.
Hello, everyone. This is Dr. Willie Chi. I'm from the University of California, Davis. I'll be discussing an overview on COVID-19 VTE. I do not have any disclosure related to this talk. This is my agenda for today. Now, we all know by now that COVID exerts its effect on endothelium through a direct endothelial insult and systemic inflammation. Now, looking at some of the clinical data from the Netherlands, now let's first focus on the slide on the right, that we know that 31% of these patients develop thrombotic complication, and that includes both venous and arterial event, and PE being the majority of the thrombotic event at 81%, with a 13% mortality rate. Now let's switch over to the slide on the left. Looking at the ICU patient comparing the ward patient, despite of adequate pharmacologic prophylaxis, that the COVID-19 ICU patient carries a 6-fold increased risk of VTE formation than the ward patient. Now, if you were to summarize most of the published trial available, then we know that despite of standardized thromboprophylaxis, COVID patients still develop VTE rate at a very high risk at 27%. Now, looking at two of the recently published trial, first is the prophylaxis for thromboembolism in critical care randomized trial. Looking at delta parent versus heparin, we can see that the VTE rate is 5.1% versus 5.8%. The H1N1 infection that happened in 2009, which is a closer cousin to COVID, has a VTE rate of 13%. Again, despite of adequate prophylaxis, these rates are quite high, but certainly much lower than the 27% we see in the COVID patient. So several hypotheses has been generated that could it be the low antithrombin level led to the resistance of heparin agent, and could high fibrinogen level reduce efficacy of prophylactic dose of heparin agents. Having said that, more evidence point towards that this is the immunogenic insult to the endothelium rather than an index coagulopathy event. Again, without going into detail, we know that there is difference in fibrinogen level and PGT and APGT levels between the COVID-induced coagulopathy versus the DIC patient that we typically see in infections. Now, if we were to look at specifically the endothelial markers, particularly soluble thrombomodulin level, suggesting endothelial damage, we see that those with high soluble thrombomodulin level actually have a much lower survival rate than those with lower soluble thrombomodulin level, suggesting that high endothelial insult lead to a lower survival rate. Having said that, despite of the high VT rate, these patients who are at high VT risk also are at high risk of bleeding. Again, using Padua prediction score greater than 4, we see that 11% of these patients are high risk of bleeding. So what the compression use? I'll be discussing few meta-analysis. This is first of which 16,000 patients, 70 trial, both surgical and medical patient. You can see that IPC, or intermittent pneumatic compression pump, versus placebo, that IPC is much more favorable than control in terms of overall PE and DVT prevention. The same is true comparing that of IPC to TED. Having said that, when comparing IPC to drug therapy, you can see that the advantage no longer exists, meaning the IPC is just as good as drug therapy in terms of overall VT prevention based on this meta-analysis. Having said that, the bleeding risk is real, and again, in terms of bleeding risk, we see that IPC is actually in favor versus drug therapy. Now let's switch over to another meta-analysis. This came from the Korean group looking at 8,000 patient, 12 trial, both primarily medical patient. And comparing IPC versus control and versus drug therapy, the conclusion is that in terms of medical therapy, it is better than IPC use, but in terms of bleeding risk, IPC is better than low molecular heparin or heparin use. Now, PREVENT trial is one of the more pronounced prospective randomized trial that was published a year ago, comparing IPC plus drug therapy versus drug therapy alone. And the conclusion is that the overall event rate is 3.9% in the IPC group and 4.2% in the control group, suggesting that adding IPC to existing pharmacologic prophylaxis did not offer patient any advantage. Now, this is the last meta-analysis, which was recently published. Again, this is primarily in both surgical and non-surgical patient, 7,000 patient, 8 trials. The conclusion of this trial is that IPC plus drug therapy has a better advantage than drug therapy alone, and most of the advantage is actually seen in the surgical patient, but certainly the medical patient is also true. It's just that the advantage is not as robust, and that's actually applicable for both DVT prevention and PE prevention. So in conclusion, that in COVID, VT prophylaxis, despite of VT prophylaxis, these patients are at a high VT rate, and that the rate remains elevated even 4 to 6 weeks post-discharge. Certainly a concern of bleeding in COVID patient is real and need to be accounted for. So until we have a better handle on VT rate in COVID, all tools, including IPC use and compression stocking, should be available at the hands of the healthcare provider. Thank you.
Congratulations to Professor Chi for the always brilliant presentation. And now we have the question from Dr. Oshino from Fukuoka Sano Hospital, Japan.
Thank you for the presentation, Dr. Wei Chi. I'm Yuji Hoshino, other discussant of your presentation. The question: the prophylactic use of anticoagulants, IPC, and compression stocking. My question here is the indications of these methods for the COVID-19 patients. Could you let us know if there is a guideline regarding the VTE prevention for the COVID-19 patient in the United States? Thank you.
And while we are waiting for the question of Professor Chi, I would like to remind everybody you can make question in the questions and answer box, and they will be answered during the week. So, Willie, are you here?
Yeah, I'm here. So that's a, sorry, I didn't plan on taping it, so I'm going to answer this live. So I think it's a very good question. My answer is that number one is COVID is certainly a disease process that's less than a year old. So we don't have a consensus at least in the States in terms of overall VT management in the COVID patients. So we apply what we already know, that in the sickest of the sickest patient, they need to be thromboprophylaxed medically, whether it be heparin agent or low molecular heparin agents. And then in addition to that, they will need intermittent pneumatic compression pump. Certainly that's true in our ICU patient. So from that standpoint, the question really is related to what do we do for these patients who are discharged, because these patients remain at high VT risk. As I have stated, that 4 to 6 weeks, even after discharge. So in those patients, if they could certainly obtain pharmacologic thromboprophylaxis, that would certainly be a good option. For those who are not able to get post-discharge pharmacologic prophylaxis, certainly compression stocking will be a viable option. Post-discharge patient typically do not get intermittent pneumatic compression pump just because of the cost. So that's my answer to the question. Thank you.
Thank you so much. Brilliant answer. And I wish you a good night. And thank you again for having joined us. While I would like to congratulate Professor Lorena Grillo for being with us in the middle of the night from Costa Rica, it's my deep honor and pleasure to introduce her talk about post-thrombotic syndrome best management. Dr. Grillo is one of the leading figures in Costa Rica, particularly for phlebolotomy initiatives. I really suggest you to attend her meetings as soon as possible. And here is her talk.
Good afternoon, everyone. My name is Dr. Lorena Grillo, vascular surgeon from San Jose, Costa Rica. I want to thank the Japanese Society of Phlebology for the invitation to participate in this international session. I have no conflict of interest. I'm going to talk about the post-thrombotic syndrome best management and the gaps in the consensus that we have at this day. And definitely post-thrombotic syndrome is one of the most frequent complications of venous thromboembolism, affecting negatively the quality of life of patients and causing relevant burden to the healthcare systems worldwide. And these gaps have so many variables in which scoring is one of the things we agree to disagree. And we want to look for more pathophysiology and risk factors data that are homogeneous within the different trials to have more information about them and be able to know more about the prevention that was implemented in each case to further go for the management in compression pharmacology therapy, QOL assessment, and complications management. And these venous thromboembolism research priorities, that was a statement from the AHA and the International Society of Thrombosis and Hemostasis, goes from research, human level, patient level, practice level, and community and population level. That will lead us to have information regarding thrombosis versus embolization, hemostasis versus thrombosis, role of biomarkers, new anticoagulant targets, thrombus characteristics, being able to select catheter therapies, role of adjuvant therapies, define prophylaxis thresholds, methods to implement evidence, and also being able to put all this data in electronic health records, tools that will lead us to an easier population-based studies and treatment for special populations data. Also, with economic and health status measures, we can be able to have more impact in public awareness and have a really complete variation in healthcare delivery. And we have different classifications in CVI and PTS, CIAP, BCSS, B-Alta, Ginsberg, and branches with different pros and cons each. And regarding B-Alta, I could say it's 5 symptoms that will be patient self-reported, 6 signs that will be by clinician assessment, with a severity from 0 to 3, and a range for no PTS from 0 to 4, mild from 5 to 9, moderate from 10 to 14, severe from 15 or over, or if the patient has ulcer present. The risk factors of DVT diagnosis that are most important are the DVT location, the elevated body mass index over 30, pre-existing CVI, previous ipsilateral DVT that would have a 6 to 10-fold increase of risk, and early sub-treatment will increase it up to 15-fold. So it's very important. And age also will have a 30% to 3-fold risk augment. And risk factors for developing PTS syndrome in regards to anticoagulation, we will have to look at the quality, the choice of treatment, and the role of thrombolysis regarding the clot structure and fibrinolytic potential in each patient with post-thrombotic syndrome, also with the duplex findings and biomarkers. In post-thrombotic management, compression therapy, it will be a very important role in order to have it installed in the 24 hours after diagnosis, and as soon as it's possible. The best will be in preventing post-thrombotic syndrome. Up to 8% in patients, we will be able to lower the burden of clot in the vessel. And use pharmacological treatment also in addition to exercise instead of bedridden patients that were as they did before. And we want patients moving, but with the appropriate compression stockings available. Being able to perform and know more about the outcomes and indications of Indominus procedures, angioplasty and or stenting. And more studies have been available about percutaneous valve placement, venous valve surgery, and more are to come with a bigger number of patients enrolled in each trial or study. So which are the gaps that we want? We want to close all these gaps to be able to achieve consensus. And I suggest the use of symptomatic or asymptomatic chronic venous thromboembolism rather than PTS of the lower extremity, upper extremity, or pulmonary chronic venous thromboembolism. Through research, we'll be able to get the knowledge of epidemiology and risk factors to define and standardize these parameters, to modify the ones that are possible in order that we can prevent severe PTS syndrome and ulcers, and also venous claudication. Through breast prevention, we have the opportunity to have the adequate venous thromboembolism diagnosis and treatment, and promote the call to action from research to public awareness, as we talked about. So what are we aiming for? We want to lyse the clot, do it promptly and early to have a favor restoring vessel patency and preserve valve function. We have to do it in the best choices in management through adequate initiation of compression very early on, pharmacologic treatment, and multidisciplinary approach. We want to narrow the range and reduce the severity of these symptoms, so we don't have so much incidence of patients with leg ulceration or venous claudication. I thank you very much for your attention, and I want to thank especially the Japanese Society of Phlebology for having me participate in this session. Thank you.
And I congratulate once again Dr. Grillo for a wonderful presentation. I know that the Professor Takashi Yamaki is at the same time involved in another session, so we will have a direct question to Dr. Lorena. While we are waiting for the audience to eventually prepare a question, I'd like to ask you, Lorena, if you have information about eventual risk of false positive with Villalta score for PTS, and how we could eventually be careful for that.
Mm-hmm. I think that is a very important question, and there's a high rate of false positives. So we always have to take in account, as Dr. Fedor Lauder is putting his study, that we could also have almost like a 42% false positives with Villalta scale scoring in the diagnosis of post-thrombotic syndrome. So we have always to exclude chronic venous insufficiency with the other scores we have, and also the previous history of the patient.
This is an outstanding answer. Is the audience having any answer for Dr. Grillo? Is somebody looking forward for making a question? If not, I remind you that we have the question and answer box, and we deeply thank once again Lorena for being here live in the middle of the night from Costa Rica. And I hope you will meet her in Costa Rica or in Japan soon. It's my deep honor and pleasure to introduce another leading figure from Latin America and dear friend for many of us, a visitor of Japan multiple times, Professor Luis René Villarroel. And he is here, his presentation.
Thank you very much for the invitation. And
for sclerotherapy treatment in venous ulcers. Advanced stage venous insufficiency is characterized by the presence of varicose ulcers. These can develop for months and persistent for several years. Many of the patients who have them designed to lead a life full of limitations and with unlikely to recover. For years, pharmacological as well as surgical procedures have been developed with the aim of recovering tissue continuity in these ulcers. However, while venous insufficiency persists, it is difficult to achieve full recovery. Currently, the use of sclerotherapy has been shown to allow recovery in less time for patients who are cured of varicose ulcers with topical medication. Sclerotherapy involves applying a sclerosing agent in the lumen of the varicose vein, causing it to secrete fibrin, achieving a definitive collapse and closure of it. Objective: to check the relationship between the use of sclerotherapy and the closure of varicose ulcers. Methods: a series of cases is presented including 46 patients with venous ulcers to receive healing every third day and application of foam sclerotherapy once a week during 4 months. February to May of the year 2019. Sclerotherapy was applied using technique described by Dr. Lorenzo Tesari using tetradecyl sodium sulfate. At Arias Medical Clinic, the healing of varicose ulcers is divided into 3 periods. 1. Eliminating the infectious process. 2. Restoring adequate circulation on use of sclerotherapy. And 3. Tissue culture. Eliminate the infections process by using antibiotics that can be oral, intramuscular, and sometimes topical. Restoring adequate circulation. The use of sclerotherapy allows to completely close the varicose veins that are located on the periphery of the ulcer, and in most cases, percine and communicating veins are sealed that cause the accumulation of waste product in the area, weaken muscle tissue, and promote a favorable environment for the development of ulcerative bed infections. The use of sclerotherapy eliminates the flux points, significantly improving circulation in the ulcer area. Tissue culture. The use of topical substances allowed to promote granulation tissue, achieving to the new muscle and epithelial tissue, as the case may be pH control, in addition to the use of the comprehensive bandage decreases edema and help the process of chemical fibrosis caused by sclerotherapy, eliminating varicose veins. Results. Currently, the use of sclerotherapy has been shown to allow recovery in less time for patients who are cured of varicose ulcers with topical medications. A 72% scarring up in 33 patients was achieved, proving that the use of sclerotherapy in these patients promotes positive evolution. In addition, along 9% for patients, relapses related to other factors identified, use of bandage, hygiene, etc. In 50%, 23 patients show improvement in the aesthetic aspect, managing to reduce areas by lipodermatosclerosis on the periphery of the ulcera varicose. Below the present 2 of the most significant cases of our study. Case 1, female, 74 years old, persistent ulcer of more than 10 years of evolution. Case 1 results. Case 2, female of 42 years old, persistent ulcer of more than 3 years of evolution. Case 2 results. Conclusions. The use of sclerotherapy allows to completely close the varicose veins that are located on the periphery of the ulcer, and in most cases, passing and communicating veins are sealed that cause the accumulation of waste product in the area, weaken muscle tissue, and promote a favorable environment of the development of ulcerative bed infections. Sclerotherapy controls the points of the flux by causing blood to peak of the right path. Combined using cures with topical medication prevents recurrence and allows shortening time of scarring. It's important to emphasize that the use of topical substances indeterminate by pH control in the ulcerative bed and the use of comprehensive bandage is mandatory for the patient after the application of sclerotherapy to obtain a favorable results above.
I deeply congratulate Professor Luis Villarroel also for being here at midnight. So Luis, if you want to say a word of greetings to all our Japanese friends while we are preparing the questions for you.
Yes, thank you very much for the invitation. Special the committee from the Japanese Society of Phlebology, Dr. Makoto, Sergio, Dr. Takayiro, and all everyone. Regards here from Mexico.
Thank you for being with us so late in the night. And we have now Dr. Yoshiko Watanabe from Kawasaki Medical School, Okayama, with a question for you.
Glad to meet you. My name is Yoshiko Watanabe, Kawasaki Medical School in Japan. Thank you very much for your beautiful presentation. I'm so impressed with your great research. I thought that such aggressive sclerotherapy is available in many countries and effective to treat many venous ulcers. And I have some questions. First, did you treat the saphenous vein reflux by foam sclerotherapy alone or with any other procedures? And second, it was great that 72% of the ulcers healed up, but you mentioned that 9% of them relapsed due to insufficient compressive bandage or unhygienic conditions. So I'd like to know how long a period do patients need to do strict compression therapy to avoid relapse? And next, you also emphasize that the use of topical substance is important to control ulcer beds. I'm interested in what kind of topical substance you actually used. Thank you very much.
Luis, the mic is for you.
Well, that was all three very good questions. First of all, I used to use foam sclerotherapy because I have a lot of experience, over 29 years doing foam sclerotherapy, and that works very well combined with elastic compression. And your second question, we use antibiotic a lot, and we do in our office the varicose ulcers treatment, because many people don't have the conditions and also they don't have the knowledge to manage the protection or the care in the ulcer. And third one, we help us a lot with the topical substances, because we find in our research that when the pH is in the high pH, it needs to going down or in adverse condition. That means we have to make more acidity or more basic. We use a lot of soaps and try to put in the right pH condition. And sometimes we help us with kinesiotaping to help us with the going down the swelling of the leg. And always we use over the 3 levels, the compression treatment. we use always a bandage, elastic compressive bandage.
Thank you so much, Louise. And I remind everybody, if you want to make also comments, not just question and answer, you can report them in the question and answer box. And I'm sure Professor Villaroel and all the other faculty members will answer during the week. Now we move forward to USA with Dr. Patrick Mack, a dear friend, top key opinion leader on the field, and in particular in this case, presenting about percutaneous aspiration thrombectomy with a new device.
Good afternoon, everyone. Thank you so much to your president, Dr. Yamato, for the opportunity to get involved with the 40th annual scientific meeting of the Japanese Society of Phlebology. My name is Patrick Muck from Good Samaritan Hospital in Cincinnati, Ohio, and you can see my topic today, percutaneous aspiration thrombectomy with intelligent blood-sparing technology for DVT and PE. Here are my disclosures. I'm very lucky to be at Good Samaritan Hospital, the home of Dr. Tony Komoroto, and where Dr. Thomas J. Fogarty invented his embolectomy catheter several decades ago. As we know, death from pulmonary embolus is not due to hypoxia, but in fact secondary to right heart failure. It's simple. This is a non-collapsible catheter that's torqueable, angled, has an atraumatic tip, it engages thrombus and embolus, and can aspirate it through a high-pressure system.
Come back a little bit. You're clear.
We have had excellent results with continuous thrombectomy over the years, in particular the penumbra system.
Yeah.
However, being continuous, it can also lead to an extraction of circulating or liquid blood and an increased blood loss. That's why I'm so excited today to share with you intelligent aspiration, which is intermittent aspiration with lightning technology that's now available in 2012. It's simple. There's a dual lumen pressure system that allows for real-time flow monitoring. If it's low pressure, that means it's liquid circulating blood, and the automatic valve will close, minimizing blood loss. However, if it's high pressure, it assumes it's up against a thrombus or an embolus, and it'll allow for continuous aspiration to remove it from the system. In addition, Penumbra now has a 12 French system with a 0.131 lumen, the same proprietary separator technology. It's a stainless steel hypotube that's laser cut, and with the angulation, you can reach out to diameters up to 50 millimeters, really engaging a DVT or a PE. So ladies and gentlemen, it's the best of both worlds. Now you have minimal blood loss through intermittent aspiration, and you have a larger Cat12 medium bore aspiration system. It really effectively can treat your DVT and PE patients. Briefly, this is one of my patients, a 50-year-old, found down. He suffers from multiple myeloma. He had large bilateral first, second, and third order PA branch embolus, and you can see here that the Cat12 easily tracked over a stiff angled glide wire. Here, it easily tracks over the glide wire treating the left side. Today, I use a 1280 Cook sheath for support. Not just a great radiographic result, but an excellent hemodynamic result as well for my patient. Here's my patient, which was technically the third lightning Cat12 case in the world. You can tell a large iliofemoral DVT. I routinely use Cat12 through a posterior tibial vein or a short saphenous vein approach. If not that, I'll go popliteal. Here you see a large iliofemoral DVT, and after treatment with intermittent intelligent aspiration and Cat12, you can see an excellent single session result with subsequent de novo stenting. So ladies and gentlemen, the future is bright for our VTE patients. Thrombectomy devices are here. Cat12 French systems are here. Intelligent blood-sparing technology is here for our thrombectomy procedures. Once again, I'd like to thank the Japanese Society of Phlebology and as well as Dr. Giannisi for this incredible opportunity to join you this afternoon. Thank you.
And we congratulate with Dr. Mack, who is very probably sleeping now in the United States. He's a very nice person and a huge professional, so feel free to reach out to him also in the question and answer box with your questions or need of contacting him, because he has really a huge experience on the topic. It's our pleasure to welcome Dr. Yamada Norikazu from Ogawa Medical Center with this question to Professor Mack.
Dr. Mack, thank you so much for your excellent presentation. I'm so impressed induced system lightening is effective for the large amount of clot removal with much less blood loss for the patients with acute pulmonary thromboembolism and deep vein thrombosis. I have two questions. First question is, what is the appropriate duration from the onset of symptom of deep vein thrombosis? Second one is, I think the removal of thrombus in transit in right heart is very difficult, extremely difficult. Do you think this device is effective for the floating thrombus in the right heart?
And we thank you, Dr. Yamada, and here is the question, and this is the answer of Dr. Mack.
Dr. Yamada, greetings from Cincinnati, Ohio. Thank you so much for your interest in my presentation and your two super clinically important relevant questions. First question is that with regards to DVT patients, we offer this technology no different than we have pharmacomechanical thrombectomy over the years, namely folks who have a 10 to 15 year lifespan, who have a iliofemoral thrombus, and it's 10 to 14 days in duration. So I think we all agree across the world those are the folks at the highest risk for post-thrombotic syndrome, and therefore we offer this technology, and obviously it's super exciting to be able to do single session therapy with minimal blood loss and no thrombolytics. So I think the future is bright. However, obviously, as being researchers and academic physicians as we are, we still need more data on this device and this technology, but I think it's pretty promising. Not to mention with the Cat12, a new 12 French larger aspiration tubing makes a big difference as well. As far as your second question, as you can see, sometimes I get a little long-winded when I get excited and with technology and with my presentation, and I wasn't able to include it, but we did have one case of thrombus in transit, and as we both know, those patients are very tenuous, but it worked also, minimal blood loss, and we were able to aspirate out that thrombus in transit. So to that end, I hope to meet you face-to-face someday. I think that this technology is crazy and exciting and provides connectivity, but I sure hope to meet you someday in person. And thanks once again to the Japanese Society of Phlebology for this incredible opportunity to get involved with your wonderful meeting. I hope the rest of the meeting goes great. Thanks so much.
And we thank again Dr. Mack for his contribution. And now we fly all the way to Latin America again with the talk of Professor Daniel Onorati about 29 years of experience in the training of specialists in phlebology.
In this work, we want to show our experience in teaching the specialty, to which we owe many satisfactions, and for that reason, we want to share them with you. Although this analysis is closer to humanism than science, we deem it appropriate to classify these subjects in a similar way to conventional projects. We have subdivided the presentation into the main steps of the learning process, both from the teacher as well as the student's perspective. This project analyzes the problems faced when teaching and learning of the specialization, as well as the difficulties faced when passing on inherent technical skills. This presentation only attempts to describe a teaching experience. However, it clearly points out some remarkable aspects. We are aware of the subjectivity of this evaluation, but it was carried out with the utmost intellectual honesty and based on teaching experiences in different scenarios during an extended period. Our specialization shows distinct features that we would like to highlight, and of course bring our students' attention though. It does not present major problems from the theoretical point of view. Nevertheless, practical learning and the personal qualities of the phleboologist play a vital role for the correct exercise of the specialization. Presenting someone with a training certificate as a phleboologist represents a significant responsibility, whereby we are certain we have taught the theoretical fundamentals as well as ensuring the student possesses the necessary surgical capabilities needed in everyday practice. We highlight the equal importance of both practical and theoretical knowledge, as well as the human aspect of the student. Despite being labeled as a minor branch of general and vascular surgery, phlebology has its own features which can pose great difficulties when teaching it.
And with this, we concluded the talk, and I think we have the honor and pleasure of having him live with us, right? Is there Dr. Onorati with us, as I can see from the faculty list?
Yes.
Unmute yourself in case. Wonderful. Daniel, welcome. So we
Can you hear me?
Yes, perfectly. Thank you for being with us in the middle of the night. So we will welcome the question from Dr. Eri Fukaya from Stanford University. Eri? Can you make your comment to Professor Onorati, who is with us?
Thank you. Thank you, Dr. Onorati, for the presentation. Quick question, you mentioned the surgical skills required for the phleboologist, and you said that everybody comes from different backgrounds and require different training, but in your experience in Argentina, can you give us kind of what is the most common background for the person who decides to become a phleboologist, and what do you think are the minimal background training requirements for a person who comes to you saying that they want to be a phleboologist is?
Yes, I think general surgeons are better for learning phlebology because many techniques and many procedures in phlebology, you must to know basic improvement of surgery. For that, we prefer to teach vascular or general surgeons that clinical doctors.
Thank you so much, Professor Onorati, for your feedback. Now we have the mic for the audience. So if you want to make any comments, a question, the panel now is open to everybody to make eventual comments. And while we are waiting for them, I'd like to ask to Luis, how you envision standardization in sclerotherapy, how important it is to have the proper material and proper method, because if not, we get the risk, of course, of comparing apples with pears, as we say in Italy, or oranges, as we say in USA.
Well,
Many countries like Italy, part of Europe and US, or maybe in Japan, it is normal to have a lot of equipment, a lot of tools, very exactly and appropriate places. In the country that I work more, like Bolivia, we work places that they don't have electricity, they don't have water, they don't have the basic necessities to have a good quality of life. That it means we have to fight against a big problem, big vascular problem. The human being needs to have the right attention, medical attention. I find with foam sclerotherapy the right tool to work any place, anywhere, without this a lot of tools on a lot of technology equipment. We have a team, we working in 2 different countries, in different and many places, and we have, we figure out some things. I heard some long time ago with Dr. Scuderi, he said that foam sclerotherapy is an art. You have to encourage your talent. You have to learn for a good professor the right techniques. With the time we have a team with young doctors. We work in many places around the Amazonic place in Bolivia, in Cochabamba, La Paz, in the Andes, also in south of Mexico, in Veracruz, in many different places. And we have a lot of very good results. That it means I am very happy to have the opportunity in my life to learn and practice this treatment with foam sclerotherapy. And I try to teach new doctors and encourage them to learn, to have more practice, and they can do more work in our society.
Okay, Luis, since time is passing by, just a quick question from the queen of sclerotherapy, Dr. Pauline Raymond Martin-Beau, is following us from Canada, and we deeply thank her for being here. She's asking, do you recommend the peri-ulcer foam sclerotherapy first or proximal injection if the patient has a phenofemoral incompetence?
Of course, of course. We have to do foam sclerotherapy to correct the reflux, because the blood with vascular insufficiency is lower in oxygen and is saturated with detritus. It is very hard to healing. And with foam sclerotherapy, we have better results fast and encourage the
Luis, sorry, maybe there is some misunderstanding with the connection. The question is first peri-ulcer or proximal injection in case of saphenofemoral incompetence?
Peri-ulcer.
Peri-ulcer. Thank you so much. And now we move forward, and I remind all the faculty members and the attendees, they can make questions in the question and answer box, and all the faculty will answer in the next days, and we will post everything online. And now we move forward for the next session, but not having before deeply thanked all the wonderful faculty members who have taken part in this first session. And now we go into the competitive part, but there is actually no competitions because all these abstracts have been already selected, so they will all enjoy an award. Let's just see the ranking now. So we will start with some greetings from Professor Chi, as Scientific Director of the VWIN.
Konnichiwa, my Japanese friends and colleagues. I am Dr. Chi from the University of California at Davis. I want to thank JSP and the organizers for having me to give a topic on compression therapy in COVID. At the same time, I want to make my greetings to all of my colleagues in Japan and throughout the world that I wish I could be there. I'm pretty sure that all of us would have that wish too, but due to the crisis we're currently facing, this is the best mode of communication. I wish JSP's 40th meeting to be a great one. The meeting venue is very comprehensive and very interesting topics. And with that, I want to say that I wish that we could all meet together next year. Thank you, and arigato.
And we deeply thank Professor Chi for his presence, and now we have Dr. Yutaka from Kyorin University with his welcoming. Dr. Yutaka, are you with us?
Yes. Can you hear me?
Yes, perfectly. Thank you.
My name is Yutaka Hosoi from Tokyo, Japan. And it's my great pleasure to join this international meeting. And I really thank all participants to join us today. Thank you.
Thank you so much to you. And now we move forward with the free abstracts competition. And we start with Dr. Shimizu and his talk about the one-year follow-up results on concomitant cranial saphenofemoral junction tubular ablation with laser great saphenous vein corsectomy.
Ladies and gentlemen, thank you for Chairman. I have no interest to disclose. Anterior accessory saphenous vein insufficiency is one of the most common causes of recurrent varicose veins after endovenous laser ablation. So laser classectomy is a promising approach. However, flash or ASB occlusion rates after laser classectomies are not always satisfactory. In this patient, flash occlusion was obtained initially, but SEV recanalization was observed at 3 months, and then AASV recanalization was confirmed at 6 months. This kind of flow restoration of junction tubularties is not rare after laser classectomy. The purpose of this study was to investigate whether the new approach, concomitant cranial junction tubularties, such as the superficial circumflex iliac vein or superficial epigastric vein ablation with a laser classectomy of the GSV, would achieve higher ASB occlusion rates after EVLA or not. We retrospectively analyzed 136 limbs in 126 patients undergoing EVLA, aiming laser classectomy using a 4070 diode laser between 217 and 18. Patients were divided into 2 groups: laser classectomy only in control group and laser classectomy with CTA in CTA group. Follow-up was performed for 1 year and the results were compared between the groups. Technique of CTA included the followings. The fiber was delivered into the GSV and advanced to the junction as a standard EVLA technique. Under ultrasound guidance, the fiber tip was introduced into the SCI or SCV. After tumescent, the tubularity was directly ablated with 50 to 100 joule. And then the fiber tip was taken out to the proximal GSV and a little bit advanced towards the junction, and the proximal GSV was ablated from near the junction with higher laser energy as a usual laser classectomy technique in our hospital. And now we are going to show the results. There were no significant difference between the groups in the baseline characteristic, including the tubularity distributions. Higher leads was applied in the CTA group, but there were no significant differences in the other operative factors between the groups. In CTA group, the SCI was operated in 57%, SCV 38%. The unsuccessful cannulation rate was 24%, and CTA was performed in 62% of all laserclastectomy procedure in 2018. There were no differences in early operative results, including the incidence of E-hit between the groups. No other adverse events were observed in both groups. The AASV occlusion rate after LA was significantly better in the CTA group between 1 week to 1 year. Recanalization of ASV was sometimes seen in the control group, but it was very rare in CTA group. Flash oxygen rate after LA is also better in CTA group for 1 year. In conclusions, this new technique is a safe and an effective approach to achieve better ASV occlusion rates after EVLA. It is occasionally technically demanding, but can be a feasible option. Further investigation needed to confirm our results. Thank you for attention.
And I congratulate once again Dr. Shimizu. I have to say Japan is always at the forefront of innovations, and we have the pleasure of having once again Professor Villarroel with these questions. So please, Luis, unmute yourself and make the question.
Yes, I'm here.
Thank you. Go with the question. Luis, do you have the question for Dr. Shimizu?
Not really. I just want to say it is it was very good presentation, but really I don't have a question about it.
I will take this chance for making a question. Dr. Shimizu, I really appreciated your presentation. So we know that the terminal valve, according to a publication we did, is representing a risk factor for saphenofemoral junction recurrence. Were you able to notice any benefit with this technique in case of incompetent terminal valves?
Are you talking about risk of this technique?
Yes. No. Yes.
One is risk is E-hit, but when doing the high laserclastomy, the space of the proximal junction is very small, so E-hit thrombus formation is very small. So I think E-hit is not very important complication. And also we worried about some branch injuries such as pudendal artery fistula, but so far we don't see these complications. And so a little bit takes time to do this, but we only spend 3 minutes for this technique. If it takes more than 5 minutes, we just give it. So this is not very long procedure for the patient.
Okay, thank you. So now, congratulations again, and we move forward with the next speaker, Dr. Nishimoto from Hyogo Prefectural Nagasaki General Medical Center, and he will be talking about risk factors for major bleeding during prolonged anticoagulation therapy in cancer patients.
Thank you for chairperson. Good afternoon, ladies and gentlemen. My name is Yuji Nishimoto from Nagasaki General Medical Center. Today, I'd like to talk about risk factors for major bleeding in cancer-associated venous thromboembolism. I have nothing to disclose. First of all, patients with cancer-associated venous thromboembolism (VTE) have a markedly higher risk of recurrence as well as bleeding, leading to difficulty in achieving good risk-benefit balance with anticoagulation therapy. The recently proposed useful risk scores such as VT breath score to predict the risk of major bleeding in VT patients include active cancer as a score component. We recently reported that the VT breath score might not be applicable for risk stratification of patients with active cancer. The current VT guidelines recommend prolonged anticoagulation therapy for patients with active cancer if they are not at high risk for bleeding. However, there is a paucity of data on risk factors for bleeding specific to patients with active cancer. The purpose of the present study was to identify risk factors for major bleeding during anticoagulation therapy in patients with cancer-associated VTE. The command VT registry was multi-center retrospective cohort study enrolling consecutive acute symptomatic venous thromboembolism. The study period was from 2010 to 2040 in the warfarin era. This is study flowchart after excluding patients without active cancer. There were 695 patients with active cancer. Active cancer was defined as you can see. We also excluded patients with clinical events and loss to hope within 10 days. Finally, the present study population consists of 592 patients with anticoagulation therapy beyond 10 days after the diagnosis. There was no significant difference in the baseline characteristic comorbidities or laboratory data at the time of the diagnosis between the patient with and without major bleeding. Asterisk means potential risk factors for major bleeding in the multivariate Cox regression model. Among warfarin users, there was a numerically lower TTR in patients with major bleeding, and the patient with major bleeding had a significantly higher maximum value of the INR than patients without major bleeding. The most frequent site of cancer was gastrointestinal, 21%, followed by lung, breast, and ovary. The cumulative incidence of major bleeding was 5.8% at 3 months and 30.8% at 1 year. Major bleeding occurred within 3 months after the diagnosis in 31 patients, whereas it occurs beyond 3 months in 41 patients. The most frequent site of major bleeding was gastrointestinal, 47%. This is the main result of the present study. The multivariable Cox proportional hazard model demonstrated that terminal cancer, CKD, and gastrointestinal cancer were independently associated with an increased risk for major bleeding. I would like to summarize the results. More than half of the major bleeding events occurred beyond 3 months. Nearly half of the major bleeding sites were gastrointestinal. And finally, terminal cancer, CKD, and gastrointestinal cancer was the independent risk factors for major bleeding. In discussion, the distribution of the bleeding site was almost consistent with previous report from Reed Registry. In line with previous studies, the present study shows that terminal cancer was a strong independent risk factors for major bleeding. Clinicians should obtain a good risk-benefit with prolonged anticoagulation therapy in patients with advanced cancer. A further study would be warranted to clarify the treatment strategy of anticoagulation therapy for patients with advanced cancers. There were several study limitations related to observational cohort data and Japanese-specific problems. In conclusion, major bleeding events were common during anticoagulation therapy in real-world cancer-associated VTE patients. Terminal cancer, CKD, and gastrointestinal cancer was the independent risk factors for major bleeding. Thank you for your kind attention.
And we deeply congratulate Dr. Nishimoto, and we deeply congratulate all the Latin American friends who are still with us despite the late hour over there. And we welcome the question of Dr. Lorena Grillo from Phlebology Pura Bene. Please.
Yes, thank you, Dr. Nishimoto, for the great presentation and a very interesting topic also. Beside the independent risks you already stated in your last slide and metastatic cancer, do you think there are any other risks that should be assessed and that you could identify that were not followed up, or that you could think it will be important in another trials or studies to be addressed?
Thank you so much, Lorena. We know that Dr. Nishimoto is having a busy day at work, so could you please let me know if he's here? So if he's not here, we have already his answer recorded.
Thank you, Dr. Gulito. Very important question. There's a limited data on the risk factors for breeding specific to cancer such as BTE. So we have to keep exploring about it. As you can see, the current study population was relatively small, so other risk factors for such as anemia, thrombocytopenia, and history of major bleeding could be risk factors for major.
Okay.
Thank you.
And now we move forward with Professor Takeuchi from Fukuoka Rehabilitation Hospital from Fukuoka, Japan, with his presentation on the dimer levels after treatment of perioperative venous thromboembolism in orthopedic patients.
Good afternoon, ladies and gentlemen. My presentation today concerns investigation of D-dimer levels after treatment of perioperative venous thromboembolism in orthopedic patients. We sometimes experience an elevated D-dimer after improvement in VTE. I think meaning of high D-dimer unless VTE disappearance in this study. I have no financial conflict of interest to disclose. To give you some background, D-dimer is generally used to predict the effect of VTE treatment. However, in the perioperative period, D-dimer levels are elevated and thereby cannot be used as an indicator. On the other hand, D-dimer levels occasionally remain high even after disappearance of DVT. The purpose of this study was to assess D-dimer levels after discontinuation of AC in terms of arteriosclerosis. The target group consists of 84 orthopedic patients with perioperative VTE. They include one proximal type DVT and there was no cases of PE. AC with DOAC was administered to 82 patients. This slide shows strategy of AC for postoperative patients. As the proximal type, we started intensive therapy at first, then maintenance therapy was underwent, so-called single drug approach. Drug was administered at least for 3 months. In the case of distal type, which thrombus was isolated or measured 5 cm or less in length, we selected conservative therapy. If thrombus increased, we started DOAC using maintenance therapy. Duration was not always for 3 months. In cases of total knee arthroplasty, we can use edoxaban for DVT prevention. If DVT occurred, we continue AC fundamentally. We determine volume of edoxaban, taking consideration about renal function, age, body weight, and prescription of antiplatelet drug. Ultrasonography and D-dimer testing were performed 1 month after discontinuation of AC. Using a D-dimer level of 1.5 microgram per milliliter as a cutoff, the patients were divided into 2 groups to compare DVT recurrence and pulse wave velocity. Comparison between the high and lower D-dimer groups after discontinuation of AC found that patients in the former were older, included higher percentage of female, and higher D-dimer levels after surgery in 2 postoperative days. This slide shows the proportion of each DOAC. Edoxaban was generally used in 51% cases, following rivaroxaban in 30%, apixaban in 70%. After excluding 2 patients with distal type DVT, AC was administered to the remaining patient. DVT improved in all cases, and the disappearance rate was 88%. The mean days until DVT disappearance was 29 days, and the mean duration of AC was 55 days. The DVT recurrence rate was 36% in the higher D-dimer group, which was significantly higher than 30% in the lower D-dimer group. This graph shows relation between D-dimer level after VT improvement and pulse wave velocity. There is significant correlation between D-dimer and PWV. In cases which had high D-dimer level after VT improvement, we should pay attention to atherosclerotic risk. The atherosclerotic risk in community study shows correlation between D-dimer levels and incident VTE. In conclusion, this study clearly shows that higher level of D-dimer is a strong risk factor for past VTE. In this study, the target was a proximal DVT patient, including 77% unprovoked DVT. An increased intermediate thickness was shown more often with residual vein thrombus than without thrombus. This research leads that residual vein thrombosis after an episode of proximal DVT is associated with a higher prevalence of subclinical atherosclerosis. Here's our conclusion. Patients whose D-dimer remained high after improvement in VT were elderly and had a high VT recurrence rate. There was correlation between D-dimer level after VT improvement and pulse wave velocity. D-dimer tend to be high in patients with advanced arteriosclerosis. I think that it is important to diagnose VT as soon as possible and to start the anticoagulant therapy with drugs in order to reduce thrombus volume. I appreciate your attention to my presentation.
And I really congratulate Dr. Takeuchi for the always brilliant presentations received from Japan. The quality is always really high with the Japanese Society of Phlebology. We have the pleasure of having Dr. Malay Patel from India with us. Malay, can you hear us?
Yes, I can hear you, Sergio, and thank you for having me here. And I thank the Japanese Phlebology Association for having me here on the 40th occasion. And my question is to Dr. Takeuchi is that now, is it very prevalent in Japan to only use the DOACs? And the second question is that the duration that you talk about is 3 months. There is a gap of about 1 month before you do the testing. Do you think that that 1 month of testing or the gap puts the patient more at risk? And second and thirdly is, once you find high D-dimer levels, do you extend the duration of the DOACs and for how long? Thank you very much. And I thank you in advance for answering my questions.
Thank you for your question, Dr. Murray. That is a very important point. Among these drugs, rivaroxaban has best treatment effect as the DVT disappearance rate in our experience. Rivaroxaban can be used for 3 weeks with intensive therapy. So I think it is suitable in cases with large thrombus volume. It is important to check coagulation system by calculating prothrombin time during anticoagulation therapy at least 1 time. The second question is how during continue the drugs. I think at least 1 month continuing drugs, then check echo testing Doppler scan. DVT is disappearing. I stopped drug, and after 1 month discontinuation of drug, recheck echo. So if DVT is not existing, drug is stopped. I think I start this drug. Thank you for your questions.
And congratulations again to Dr. Takeuchi, and thank you to Malay for his contribution. We will have an audience session at the end of this abstract discussion, so feel free to put all the questions you have in the question and answer box, not in the chat, please, just in the question and answer box. The chat is for social communications, so your questions in the question and answer box, and we will be answering to them during the final part of this session. Now we move forward with the next abstract presentation, and it is from Dr. Nishibe from Eniwa Midorino Clinic, Hokkaido, Japan, about the time course of leg edema after Indominus radiofrequency ablation for staphenous varicose veins.
Today, I would like to talk about time course of leg edema after intravenous radiofrequency ablation for saphenous varicose veins. Edema is defined as abnormal fluid accumulation in the interstitial tissue due to an imbalance in fluid homeostasis. Varicose veins are one of the main causes of leg edema. The prevalence of leg edema in varicose veins is reported to be as high as 14.7%. The purpose of this study is to quantitatively evaluate leg edema in patients undergoing radiofrequency ablation for saphenous varicose veins using bioelectrical impedance analysis and elucidate the time course of leg edema after RFA. 87 patients and 128 legs were included in this study. The patient underwent endovenous radiofrequency ablation. Leg edema was evaluated with BIA. BIA uses impedance obtained from weak electrical currents and estimates body composition including intracellular and extracellular water as well as muscle and fat mass. This is a measurement form of BIA. Leg edema is described as ECW per TBW. TBW is total body water, ECW is extracellular water, and ICW is intracellular water. In this study, ECW per TBW more than 0.4 was defined as having leg edema. This slide shows patient characteristics. The mean age was 65 years and female sex was 63%. The clinical symptoms were C2 saphenous varicose veins 73%, C3 leg edema 12.5%, and C4 skin changes 14.1%. The etiology was all primary varicose veins. Preoperative ECW per TBW was 0.393. When compared to preoperatively, ECW per TBW significantly increased to 0.394 at 1 week and significantly decreased to 0.391 at 1 month. Preoperatively, 20.3% had leg edema and 79.7% had mild or no leg edema. At 1 week and 1 month, leg edema was recognized in 23.4% and 10.2% respectively. Leg edema was significantly increased at 1 week and significantly reduced at 1 month when compared to preoperatively. The following mechanism of leg edema after RFA may be considered. Early increase of leg edema reflects the heat-induced injury of the target vein and the surrounding tissues by RFA. Rate reduction in leg edema is due to the disappearance of the heat-induced injury as well as the improvement of venous reflux by RFA. In conclusions, to our knowledge, this study is the first to quantitatively demonstrate the time course of leg edema after RFA using BIA. Leg edema temporarily worsened in the early postoperative period, but it is improved when the heat-induced injury of the target vein and the surrounding tissue is recovered and the venous reflux is abolished by RFA. Thank you for your attention.
And I congratulate Dr. Nishibe. Indeed, the quality remains really high. And it's our pleasure to welcome Professor Flores from the National University of Asunción in Paraguay. I know that he's here with us, right? So, Dr. Flores, if you can unmute yourself.
Thank you very much. I am glad to see again to one of my ancient mentors in Japan, Professor Nishibe. It's a very interesting presentation, and I have one question. One is, since the bioelectrical impedance analyzer induces an electrical flow through the limb, is this alternative dangerous for patients with some conditions like those who has cardiac pacemaker? Is this method applicable to any kind of patients? This is one question. And another is, do you think this method is suitable to check the improvement of other clinical conditions like patients who suffer from leg edema because of cardiac insufficiency or hypothyroidism? Thank you.
Thank you, Dr. Flores. Dr. Nishibe.
Thank you, Jorge. So I'm very happy to meet you again in this meeting. So the first question, so as you say, so BIA is cannot be used for patient with cardiac pacemaker. The second question, could you ask me again? What is the second question?
I see that this method is very useful for patients who suffer from limb edema, a patient with varicose veins. But I think you could use this method for patients with limb edema because other clinical conditions like cardiac insufficiency. I mean to check the improvement of the treatment. Is it possible?
Yes, that's possible. So BIA can be used for patients with lymphoedema, cardiac insufficiency, and some post-surgical conditions. Thank you for your question. Thank you.
Thank you so much to Dr. Flores and Dr. Nishibe, and particularly to Jorge for being with us so late in the night. And then we go toward the end of the abstract session. We have Dr. Yugo Yamashita from Kyoto University. The talk is about COVID-19 and venous thromboembolism in Japan.
Good evening, ladies and gentlemen. Today, I'd like to talk about COVID-19 and thrombosis, entitled COVID-19 and venous thromboembolism in Japan, from the joint questionnaire surveillance results. I have nothing to disclose. Background: several studies reported a high prevalence of venous thromboembolism, VTE, including pulmonary embolism, PE, in hospitalized patients with coronavirus disease 2019 COVID-19. However, there is a scarcity of data on current status of VTE patients with COVID-19 in Japan. In the first place, the incidence of VTE in COVID-19 in Japan is completely unclear. Thus, in a collaborative effort with Japanese Society of Phlebology and Japanese Society of Pulmonary Embolism Research, a questionnaire surveillance for COVID-19 and VTE has been conducted. In July 2020, a questionnaire regarding management strategy for anticoagulation, the number of patients hospitalized for COVID-19, and the number of patients who developed VTE after diagnosis COVID-19 from March 2020 to June 2020 was distributed among the members. This slide shows the participating institutions. A total of 837 institutions were included, and 77 institutions responded to the questionnaire, and the total response rate was 9.2%, which included 32% of university hospitals and 42% of certificated institutions for infectious disease. Among 77 institutions, only 16 institutions had specific recommendation for prevention of VTE with anticoagulation, such as recommended for all patients hospitalized in ICU, or recommended for only high-risk patients hospitalized in ICU, or recommended for patients with high D-dimer levels. However, the rest of vast majority of institutions, 79%, did not have specific recommendations. In the questionnaire surveillance, a total of 1,243 patients with COVID-19 among all institutions were evaluated, and 7 patients experienced VTE occurrence. So the incidence rate of VTE was 0.6%. Among the 7 patients, 5 patients developed PE. So the incidence rate of PE was 0.4%. The current questionnaire surveillance has suggested that management strategies for the prevention of VTE by anticoagulation in COVID-19 could be varied widely according to institutions. As the number of patients diagnosed as VTE in COVID-19 in Japan was quite small compared with reports from other countries in Japan. However, it has been unknown whether these results suggest an underdiagnosis of VTE in COVID-19 in Japan or actual lower prevalence of VTE in Japan. Further studies are warranted to confirm these results. On behalf of the current Joint Questionnaire Surveillance Task Force, I truly appreciate the support and collaboration of all the members. Thank you all very much.
And I deeply congratulate Dr. Yamashita for the wonderful job. We have Professor Young-Wei Chi from the University of California, Davis, making his question.
Hello, I am Dr. Chi from the University of California, Davis, and I'll be discussing an abstract that was presented by Dr. Yamashita from Kyoto University on the topic of COVID-19 and VTE in Japan from a joint questionnaire surveillance result. My question to Dr. Yamashita is that you had reported a very low incident of VTE in COVID in Japan. Based on this questionnaire, the incident rate was only 0.6%, much less than what we see both in China and of the West. My question to you is, could this low incident rate be due to a sampling error, such as underreporting, versus the fact that there is low surveillance for patients who may be subjected to have VTE? And the last but not the least, that if this is the true incident rate, could this be some form of an environmental or genetically predisposition? So thank you.
And we thank you, Professor Chi, for his contribution, and here is the answer of Dr. Yamashita.
This is Yugo Yamashita. Thank you so much for your really important questions and comments. So COVID-19 and venous thromboembolism VTE is a really big issue all over the world, but actually in Japan we don't have much data about this issue, so we conducted this questionnaire surveillance for the purpose. And the result is a little bit contrary to expectations, which reveals a quite low rate of VTE in Japan. But the reason of this lower prevalence is actually accurate reason is unknown. So as you pointed out, it could be due to underdiagnosis, including the underreport of VTE, and of course some issue of environmental surveillance could be possible. And of course the prevalence of VTE in Japan could be actually low compared with the Western country, but personally, in my opinion, considering the relatively higher rate of VTE report from China, China is the same as a country, so in Japan we could have relatively more patients of COVID-19 with VTE. So I personally think the underdiagnosis of VTE in COVID-19 in Japan could be possible. Of course, one possible reason is underreport, because this is a just questionnaire surveillance, so we need a more accurate cohort or registry-based study to answer for your questions. Thank you.
And I really congratulate once again all the speakers of the free abstract session, one of really the best ones you can find around the world. And now we have time for the audience, so I really welcome everybody to put their questions in the question and answer box so we can answer to them live. We will start with Professor Villarroel, who is so nice to be still with us, together with also Jorge and Lorena. He actually received a question before, and maybe you can answer live now, Luis. The question is from Elias, and the question is regarding sclero of venous ulcer. Do you prefer anticoagulant prophylaxis? Second question, do you inject perforator or subalcers venous plexuses? Luis?
Well, they are very good questions about that. I don't use anticoagulant prophylaxis because I think it is like working against that. I have the results that I'm looking for doing always without anticoagulant prophylaxis. About the second question, if I do prefer perforator or subalcers venous plexus, that it depends of the results of the ultrasound study. Before we do it, we do any procedure, we review the case. Every case is different, and the results give me the orientations to do my plans to do the procedure. That is very relative, but I cannot do it the same procedure for everyone.
And I think that the questions are indeed really interesting and are paving the way for further discussion. So I would welcome all the Japanese colleagues to answer to this question based on their experience. We recently had a webinar dedicated, for example, to sclerotherapy, COVID, and anticoagulations, and it should be stressed out, I think, the difference between sclerotherapy process and a thrombotic process, because, for example, in Italy, there is a lot of confusion between the coagulation process that is generated by sclerotherapy, which is a sclerosis, which is different from a thrombosis.
Yeah, that's very, very good point, because foam sclerotherapy, it is a very controlled process of doing stop, or it's not a migrated thrombo. It's very localized and controlled procedure. That's why we don't have to worry about doing anticoagulation. We never needed that because it's always under control, that procedure.
Of course, considering this is an educational activity for colleagues of different experiences, for the juniors, we also want to stress out that when we are talking about sclerotherapy, it must be a properly performed sclerotherapy with the proper material and proper technique. Anticoagulation, according to the European guidelines, for example, is not a contraindication to perform sclerotherapy. So if the patients are under anticoagulation treatment, we can perform sclerotherapy as well without particular concerns. At the same time, we should remember that sclerotherapy is not more thrombogenic than the other procedures we are usually doing according to the literature. Actually, it is less. But of course, we have always to stratify the thrombotic risk of the patients, I think. And the question I like to make in this case to Dr. Yamashita is, if he can hear us or not, I don't know. In case, please let me know, Dr. Yamashita, if you can reply, would be to brainstorm if we should give 2 extra points in the Caprini score for all the suspected asymptomatic positive COVID patients. Because in this moment, we should really focus, of course, in giving proper risk scoring. So what is your experience, Luis, about this? Do you tend to consider everybody as asymptomatic positive potential patients, so you give him 2 extra points in the Caprini score or not?
Yeah, that is very good question. In this situation, I'm thinking everyone is considered in our protocol like a COVID positive. We consider everyone. We suspect everyone could be COVID positive. In this case, in my own experience, we have to think about we have different types of sclerosants. We have 2 different types of experience in the professional to do it, the procedure. I have patients the past of COVID positive, and after that coming to my office. Honestly, I keep doing the same protocol that I doing before, always following the tests, the proofs, and doing a follow-up after 3 days, trying to do a follow-up more extremely careful about that, but we didn't see any difference in foam sclerotherapy with or without COVID positive results.
An interesting publication that was recently put on Phlebology was showing, of course, the D-dimer variations following sclerotherapy, for which if you are between 0.5 and 1, for example, is more a sclerotic process rather than a thrombotic. I would welcome all the experts in the faculty to comment on this, and in particular Dr. Takeuchi, if he can hear us and he wants to make a comment on the use of D-dimer in COVID patients, of course, and also in patients after sclerotherapy.
Yeah, we know that.
Is Dr. Takeuchi with us? In case, please just answer. And just for a variety, Luisa, I'd like to hear Lorena, so we are sure she's not falling asleep because it's 2 a.m. Lorena, do you have a comment on this as well?
We are more cautious in the treatment of patients with COVID, and there's, as Dr. Chi has stated, more risk of venous thromboembolism in the patients, and also even when they are admitted to the hospital, they, at discharge, will keep anticoagulation prophylaxis for more weeks. So actually, in COVID patients, we are more cautious about it in treatment.
You. Luis, do you have a comment on this?
Yeah, the thing is that I repeat what I said before, the foam sclerotherapy is under control. We don't have a thromboembolism, migrant thromboembolism. It's very localized. I understand why, like Dr. Grillo, use prophylaxis, but
that keep the strength of the sclerotherapy. And maybe it is not that very helpful doing, if I really suspect that it's thromboembolism risk, I do prefer don't do it, anything. Just keep waiting because it's not an emergency. But if I do a foam sclerotherapy, it's for sure that I'm very secure that my procedure don't put in risk from thromboembolism.
Okay, thank you. And I'd like to have comments from Japanese colleagues. So if there are some Japanese colleagues who would like to make a comment, please simply type it on the question and answer box so I can give you the microphone. And same for Jorge from Paraguay, if you want to make a comment on your experience there. You're muted. Unmute yourself, please.
Okay, thank you very much. Usually we use a combined treatment in case of ulcers. We use the foam sclerotherapy by one side, and the other is a compression with stocking. Usually, most of the patients heal their ulcer after less than 2 months. That is our experience.
Thank you. A comment from Malay if is with us for the Indian perspective of this. And while we are waiting eventually for feedback from Malay, I would like to ask Dr. Nishibe, who really did a wonderful job, if he has any data comparing thermal tumescent versus non-thermal non-tumescent impact on the bioimpedance. Because I think that would be really interesting to see if tumescence can play a difference. If there is some of the Japanese colleagues who want to comment on this. If not, we will leave this for the discussion in the written form that you can find in the Vivian Foundation website starting from next Monday. And all the ones who will watch those videos will get the certificate of attendance as well. So at this point, we can move forward. And I deeply thank once again all the panelists and all the faculty members of this session. We go toward the end with the invited lectures part, and we have Dr. Daisuke from Tokyo Metropolitan Geriatric Hospital and Institute of Gerontology giving us a welcoming award. Dr. Daisuke?
Yes, I'm Daisuke Akagi from Tokyo Metropolitan Geriatric Medical Center. I'm a vascular surgeon. Thank you all the participants for joining the session, and welcome. And it's very great pleasure to share the knowledge and discussion of the fourth session of EVLT and sclerotherapy. Thank you again, and let's enjoy the session. Thank you.
Thank you so much. And now we have Dr. Yoon from Chiba University welcoming us again. Dr. Jun, if you can.
Thank you very much. It's my honor to be here. And just I was invited by Dr. Nishibe, so who cannot be chair in this session, so he left now. So from the standpoint of diagnostic and interventional radiologist, so this session is very interesting. Can you hear me?
Yes, perfectly. Thank you.
Okay. So from the standpoint of Japanese doctors, so concerning Dr. Yamashita's investigations, I asked my colleague in my hospital, he's a pneumologist. He confessed he didn't investigate any VTE in COVID patients because of the risk of COVID infections. So that's the reason why it's underestimation, maybe. Okay.
Interesting. Okay, so thank you so much all, and then we start with the invited lectures, and we fly all the way to Paraguay, and really congratulations to the Latin America friends for the commitment of being with us in this moment, and we will start big with indeed Professor Flores from the National University of Medicine in Paraguay, talking about combined segmentary EVLT and liquid sclerotherapy for varicose veins and control on postoperative pain and paresthesia.
This work is about combined segmentary endovenous laser treatment and liquid sclerotherapy for varicose veins for decreasing postoperative pain and paresthesia. We perform it at the Baptist Medical Center in Asunción, Paraguay. The authors of this investigation work declare no conflict of interest with any medical institution nor company. Regarding the background, pain and paresthesia are common complications after endovenous laser treatment of varicose veins that affect the quality of life of patients in the postoperative period. The objective of this investigation work is to decrease postoperative pain and paresthesia after endovenous laser treatment by avoiding thermal injury of the saphenous nerve as well as several stab wounds of the leg skin. Usually, the saphenous nerve joins the greater saphenous vein from the upper third of the calf to the ankle. Thus, we apply endovenous laser treatment of the greater saphenous vein from the saphenofemoral junction to the upper third of the calf to avoid injury of the saphenous nerve by burning, as well as liquid sclerotherapy with polyjocanol guided by sonography instead of resection of tributary vein by stab wounds of the skin. We did it to diminish paresthesia and pain respectively. The focal pain experienced by the patients on the postoperative period was evaluated using the visual analog scale on the second postoperative day and then 2 months later. The visual analog scale is a scale of 10 centimeters or 100 millimeters. Then patients were asked to mark over the scale the level of pain that they feel, as well as control duplex ultrasound was carried out on second postoperative day and then 2 months later after the operation. From January of 2019 to August of 2020, we operated 59 patients at our department with a diagnosis of varicose vein. The diagnosis was made by physical examination and then sonography. Among our patients, there were 39 females and 20 males. It means 66% for female and 44% for males. Regarding the reasons for consultation, the most frequent symptom was pain followed by varicose veins, ulcers, heaviness, edema, itching, and cramps. Regarding the clinical, etiologic, anatomic, and pathophysiological classification, the most common presentation was varicose dilatation followed by edema and healed ulcers. To measure the postoperative pain, we apply the visual analog scale. This scale goes from 0 to 100 millimeters, and we ask the patients to mark over the scale the level of pain that they feel at the second postoperative day and then at the second postoperative month. The mean value of pain that they feel decreased from 32.3 at the second postoperative day to 1.3 at the second postoperative month. None of them feel pain at the level of the calf by the end of our examination. Discussion. The frequency of pain syndrome according to the literature is very variable and can achieve 43%. In our study, the incidence of pain syndrome was only 1.3%. Paresthesia, according to the literature, is found in 1.8%. We didn't find cases of postoperative paresthesia 2 months after the operation.
Combined endovenous laser treatment with liquid sclerotherapy is a reasonable alternative for decreased postoperative focal pain and paresthesia after varicose veins operations.
And we thank you, Professor Flores from Paraguay, and we welcome our host, actually, Dr. Takayiro Imai from Nishinoku Hospital in Nara.
First of all, thank you for joining us today. I know the time difference between Paraguay and Japan is 13 hours. I really appreciate it. So, Jorge, let me make sure, why do you think the segment ablation is effective for decreasing postoperative pain compared with standard ablation? What do you think about it?
Well, one of the reasons is because we avoid injury of the saphenous nerve. We just do an endovenous laser treatment from the saphenofemoral junction down to below the ankle. And we avoid the place where the saphenous nerve joins the saphenous vein. Below this level, we just use sclerotherapy. And also, many surgeons perform several stud wounds to cap and ligate the branches of the greater saphenous veins. We use just sclerotherapy to close these veins. This is the reasons, because we can reach a better outcome avoiding postoperative pain. Also, the cosmetic outcome is very well. We avoid several wounds at the level of the cuff.
Yeah, I see your point. One more simple question, okay?
Sure.
Okay.
What about the postoperative complications? Did something happen?
Well, we just had some patients with slight pain at the level of the thick, but we didn't have any patient with paresthesia nor pain at the level of the calf. I know that the number of our patients is not so high, but anyway, this is we achieved a good outcome with this alternative of treatment.
Thank you for a wonderful presentation.
And indeed, thank you so much, and congratulations, Jorge, for the outstanding presence, and particularly for doing that so late in the night. It's my true honor and pleasure now to virtually fly all the way to Germany or Switzerland, because Professor Rage is in between the two countries for work always. He's defined as the phleboologist from the future, because he has always bright new ideas, and here is the latest one.
Hello, dear friends in Japan. At least we meet online. So I give a talk now on viscous biomatrix, sclerofoam, and new therapy for large recurrent varices. I have no disclosures. You will know that recurrent varices are a kind of malignant structure progressing with time. They occur very frequently after ligament surgery, less frequently after interventional treatments. They are usually extremely tortuous with variation of small and large lumen parts, and it's very usual they are connected to the deep veins. Common sclerofoam is hardly sufficient for those large veins. We developed an improved kind of microfoam using blood proteins from the patient's own blood to stabilize the foam by exposure to temperature before mixing with gas and sclerosant. In microscopy, you can see that there is a very smooth, small bubble image, and so this is to make sure there are no larger particles than 20 micron. It's more a gel than a foam, and it's stable like a gel when you compare it to the common microfoam, which collapses rather fast. In this pilot study, we included 85 patients, all with very large and tortuous recurrent varices. We used biomatrix sclerofoam in a prototype laboratory prepared with the toxiclerol 2%. And there was no external compression applied except the vena film, compression film bandage for 2 weeks for large superficial varices. You will see this later on. In principle, it's very, very easy. You mark the veins, your targets, you puncture them, you evacuate the blood, you administer the microfoam, and then you apply a plaster on the puncture sites for 5 minutes, and then maybe optionally you cover it with a film. So this sounds very, very easy. This is a practical example where the majority of reflux originates from a large perforator, 15 millimeters diameter. So, and this is a rather complex structure, and it could take a very, very long time to get it fixed. Puncturing even of tortuous veins is not too complicated if you have some experience.
Well, let's see if it is advancing properly. Yes.
Here you see that we let the blood evacuate until the foam exits these valve to make sure we have no competition with blood remnants. Within a time of 11 to 21 minutes, it is finished, even for those complex structures, which is rather surprising. This is during the treatment, and the right image shows how it looks after the placement of vena film. In result, we had one-step treatments in 96.9% of the cases. Just very few needed a second foam application. That's very unusual if you're talking about sclerofoams. There was not a single complication, no DVT. Even more important, during 1 year follow-up, we had a closure rate of 91.4%. Also, this is very, very unusual. It works well for small varicosities. It works well for medium-sized varicosities. It even works for very large varicosities. And as you saw, it works for very, very complex structures. And if you imagine that this is just next day with almost everything even looking perfect, you will see and you will understand how excited the patients are when they receive this kind of treatment. In conclusion, we can say from this initial experience that the prototype is safe and effective. It reaches tortuous, non-crossable and remote targets. It's easy, fast and comfortable. I think the manufacturers will provide an application kit within the next, or in the year thereafter. It sometimes takes later than expected, longer than expected. But we are looking forward to this event, and you'll be the first to know. Thanks for listening to my talk, and I wish you all the best, and hope we'll meet again very soon in reality. Enjoy the meetings, enjoy the Congress. Goodbye.
And we congratulate and thank Dr. Rag. We welcome the question from Dr. Daisuke. You're here live, so would you like to give the question live, Dr. Daisuke?
Yes, I'd like to give a question on live. So, but I'm afraid that Dr. Rag isn't join the session.
He's having technical issues with the connection, but we will get the questions and we'll try to have him during the final discussion. So what is the question, Dr. Daisuke?
Yes, I have two questions. It's a very interesting and very curious procedure. One question, how do you distinguish this biometrics viscous sclerotherapy from the conventional foam sclerotherapy?
Okay, and you have a second question?
Second question, if you have time, I'd like to, how much volume do we need to inject to treat the whole side recurrent varicose veins? For example, in such, in the slide cases?
Okay, thank you so much. Now we will try to reestablish connection with Dr. Rag, and meanwhile we move forward, so we'll get to the answer of this at the end of this session.
Thank you.
And thank you so much again, Dr. Daisuke, for your contribution. Now it's my deep pleasure to welcome Dr. Malay Patel from the Venous Association of India. Thank you for being here with us also live. We will play his video about complications in foam sclerotherapy and how to avoid them, and we will enjoy then the discussion.
It is a great pleasure for me to be here, and I thank you for being here too. These are the contents of my talk, and I have divided these into 9 different categories, and I will go through one by one. The definition of sclerotherapy is the targeted chemical ablation of varicose veins by intravenous injection of a liquid or foam sclerosing agent. The treated veins may be intradermal, subcutaneous, endotransfacial, as well as superficial and deep in venous malformations. Sclerosing agents are of 2 types, sodium tetradicyl sulfate and polydocanol. Source them from a supplier that follows current good manufacturing practices. Because in the past we had an experience wherein the molecular formula was similar, but the structural formula was different, and that created problems in a few of our patients. Carbitol and other contaminant levels should be undetectable in sodium tetradicyl sulfate or polydocanol. Benzyl alcohol is a part of the formulation of STD in the British Pharmacopoeia and is also an anesthetic. STD without benzyl alcohol is more painful. The hardware to use is a Luer-Lock low silicon syringe or no silicon syringe. Some use all glass syringes. These are the size of the needles, 22, 23, and 26 gauge needles, 2-way connector or 3-way stop valve, syringes that require least break loose, break away, and gliding force are to be preferred. Syringes with jerky gliding movements can spurt in sudden more than expected volumes at high pressure, and it has been noted that this can easily exceed systolic blood pressure. Certain silicone syringes can make foam unstable and shorten the duration of microbubbles. The ultrasound guidance is of utmost importance. Linear broad spectrum vascular ultrasound probe with an assistance with ultrasound is the norm. Predetermine the flow in the target, especially in the lower half of the leg, and don't inject if there is a suspicion of pulsatile flow or visualization of an artery. Visualize the sural and saphenous nerves. Now, what is the type of foam? This is described as viscous, fine bubbled, and homogeneous, and produced by the Tessari method with 1 cc of liquid and 4 cc of gas. 1 to 3% concentration of foam sclerosants are injurious for larger veins. Air has a grade 1A recommendation. Carbon dioxide is our preference. 70% carbon dioxide and 30% oxygen has a grade 2B recommendation. And so use 1 cc of the liquid, either STD or polydocanol, and 4 cc's of air, CO2 or CO2 plus O2. The injection site is from distal to proximal in my case. Some do it proximal to distal. Avoid lipodermatosclerotic areas, and in such areas the injection can be retrograde with the puncture from a relatively normal skin. 0.1 to 0.2 cc of test injection, first followed by critical observation and then push off the rest of the volume. Stop injecting 5 centimeters short of a deep vein, saphenous, or a superficial vein junction. Abort injecting if there is immediate severe pain. Start with a small volume, about 1 to 2 cc's of foam, and go up to 2 to 4 cc's at a single site. The leg elevation by emptying the veins decreases hyperpigmentation, and maximum 10 cc's as per European guidelines and 20 cc's as per Australasian guidelines has been recommended. Increase the pressure gradually on the plunger of the syringe to overcome the break-loose, breakaway force, and watch the ultrasound screen to confirm intraluminal injection. Formation of a triple banded line, 2 narrow bands and a central broad band, and retrograde flow of the foam mark the optimal injection. This is how the needle is going inside the vein, foam being injected and being followed with the ultrasound, and then you will see a triple line being formed. That is the triple line that I talk about. Extravasation: avoid syringes that require higher break loose or breakaway forces and jerky movements while gliding, as they inject unpredictable volumes. Cutaneous necrosis is very rare, and it is misattributed to extravasation. It is mostly due to an inadvertent injection into an arteriole, injecting a spider vein with higher pressure causing veno-arteriolar reflux, or there is reflex arteriospasm. And these are some of the pictures of extravasation that have been inadvertently produced, and they all look fine the next day. Special note on injection technique. Commonly, sclerosants are injected with a 2 cc or 5 cc syringe. The smaller diameter syringes generate higher pressures. In a resting syringe, the initial break loose or breakaway force is overcome by thumb pressure, and the plunger starts moving through the barrel. Injection is maintained by the glide force that overcomes the friction of the plunger within the barrel. The pressure at the tip of a needle attached to the syringe can easily exceed the systolic arterial pressure, and it is not surprising that sclerosant foam or liquid can travel retrograde or circuitously into arterioles. A study of simulated injections carried out showed that even experienced injectors can generate very high pressures. Special note on trapped blood or coagulum. Complications are very rare, but among them trapped blood is the commonest. It shows up as a painful erythematous area, and peak of a coagulated vein may be seen in the central area. It has to be evacuated and re-injected to take care of a feeder, especially if there is grayscale movement on ultrasound. This is a picture of a trapped blood or coagulum. Again, another picture. And what are the systemic predisposing factors that cause complications? And they are really attributed to release of histamine and endothelin. Are large patent foramen oval, migraine, asthma, thrombophilias, and hypercoagulable states. This is the final picture that has been put together by Francesco Ferrara of Italy, showing that the common pathway could be release of kinins and endothelin. What is the post-procedure advice? Class 2, compression may be used, immediate ambulation for 10 to 20 minutes after the procedure. Prolonged vehicular and air travel in the first week is to be avoided unless there are frequent breaks with mobilization. Any complication of pain, redness, and discoloration of skin is to be reported as soon as possible. Any change in consciousness and vision is to be reported immediately. Exposure to sunlight is not considered a factor in increasing hyperpigmentation. This is my bibliography, and you can go through this, and I would be happy to take any questions at the end of this talk.
And we congratulate Dr. Patel for this brilliant presentation, and we have the question from Dr. Takashi Yamaki.
Hi, Dr. Patel. Thank you for your nice presentation. I enjoyed your talk. I have one quick question for you. As you stated in your presentation, I believe that foam sclerotherapy is useful for patients with congenital venous malformations. I have been doing foam sclerotherapy for extratruncular form of venous malformations extensively, but I do not perform foam sclerotherapy for patients with truncular form of venous malformations so often, because a large proportion of these patients may have some form of outflow obstructions. So my question for you is, do you perform foam sclerotherapy for both extratruncular and truncular venous malformations? How do you evaluate outflow obstruction before sclerotherapy? Thank you for your nice presentation.
And we thank Dr. Takashi Amaki also for being one of our hosts today. And so we have Malay with us, I think. Malay, are you here?
Yes, I'm there. I'm here. I'm here.
Great.
Yeah. Thank you, Takashi, for that excellent question. Yes, it makes a lot of sense. What we do is we do treat venous malformations. I mean, predominantly venous malformations with sclerotherapy. Now, we basically do this under contrast. I mean, a radiologic guidance. Most of the times it is ultrasound guidance, yes, but sometimes when we have a malformation, then we would mix it up, the foam with some radiologic contrast and then inject the contrast. So that's a little variation that we've done. And there was a comment about Angelo saying that it is an art, and I have added to it that sclerotherapy is, or foam sclerotherapy, and sclerotherapy is an art that is waiting for its science. So yes, my answer to you is yes, that we do use this, and we have multiple sessions, and it gives very good outcomes. Thank you very much.
And we thank you, Dr. Patel and Dr. Takashi. I see we have Dr. Rag with us. Chris, if you can unmute yourself, and we have your question still waiting for your answer.
Thank you for your patience. I might have lost a part of the question because I was just restarting the system.
Sure,
now,
I asked
the answer is, sorry?
Do you have the question? Did you get the question?
I got at least the second part.
Let me ask Dr. Daisuke, who is still with us, to make the question again. Dr. Daisuke, can you make the question to Dr. Rag, please?
Okay. Hello, Dr. Rag. Very nice presentation. Thank you. And I have a first question is, how do you distinguish your excellent viscous biometric disc sclerotherapy from the conventional foam sclerotherapy?
Okay, so that's very, very easy. This preparation of viscous biomatrix sclerofoam, it contains parts of the patient's own blood, and it's the protein denaturation process which makes the foam so very different. Perhaps you could see from one of the slides that this kind of foam is very, very stable. It will not collapse within 60 or 120 seconds like the Tessari foam, but it will stay stable in vitro for maybe even 1 hour. In vivo, it's different, but nevertheless, it stays in the place where you inject it for much longer time, and therefore the effectivity is much higher due to the prolonged contact of the foam to the endothelium. So this is very, very clear by the principle, and so we have more effects. At the same time, due to the stiffness, the foam appears in the circulation less fast than the Tessari foam, which appears in the circulation within seconds or within minutes. And so that's the reason why we see so very few side effects. The quantity, which was your second question, is limited according to the general guidelines to 10 cc per session.
which is usually totally sufficient because this foam is more effective related to the injected quantity. It does not spread everywhere. It just is placed in the segments where you want it to have its effects. So the quantity is very, very effective.
Oh, thank you. Do you have any difference of the indication of these sclerotherapies? No.
Well, this kind of foam allows you to be more effective, and this makes it more appropriate to the complicated situations, like the recurrences of varicose veins, in particular after surgery. The morphology is very, very complex, and we know we can treat this with the simple common tessari foam. We can do this, but there are lots of redo sessions, and so it's a never-ending story because you never reach all the roots, and you have to be careful. And with the new foam, we think this is a big step forward. Of course, we will do comparative studies at the moment where the biomatrix foam has become a commercially available product with a standardized setting of all its features. So at that time, we'll do and show you a comparative study.
Thank you.
And thanks to you. And thanks to all the guys who are listening. My best greetings from Switzerland. You're doing a fantastic job. Thanks for the conference.
And thank you so much. Now we have some final questions from Professor Intriago from the Panamerican Phlebology Society to all of these session speakers.
My congratulations to the doctors for your excellent participation. I would like to ask a question to each of you. First, I will start with Dr. Jorge Flores. Do you think that with this combined technique, you will obtain greater fibrosis and occlusion rates in the long term? Secondly, I will ask Dr. Rack, what kind of adverse reaction have occurred with the use of the biometrics? And what treatment should be applied? And finally, to Dr. Malay Patel, what will be the treatment recommendation for patients who present post-sclerotherapy neurological complications such as venous gas embolism? Thank you.
And we thank again Professor Intriago and all the Pan-American Society and the Latin American Venous Forum as well. So we will start with Jorge. Jorge, would you like to make a comment on the question raised?
Well, we performed a follow-up of our patient by sonography. And as long as we checked them, we didn't find yet with this alternative of treatment reflux at the level of the greater saphenous vein. Till today, we got good outcomes.
Thank you so much, Jorge. We fly all the way to Germany / Switzerland, wherever you are, Chris. Your answer?
Asking for the side effects. In principle, the side effects after use of biomatrix sclerofoam is the same like with tessari foam, but the big difference is the rates are much less. So for instance, after 20,000 of different patients in which we use the biomatrix foam, we had just 2 cases of deep vein thrombosis. And the rate of the endothelin 1 release associated minor side effects like thoracal misfeelings or something like that, or what previously has been called asthma. So this happens, but the rate is below 0.1%. So things may happen, but the frequency is much less than we know it from the general use of Tessari foam, where literally all day something minor may go wrong. So there is a big difference, and we'll show this in the future comparative studies.
Thank you so much, Chris. We fly all the way to India. Malay, you have the answer for Ernesto? Malay? We are not, yes.
Ernesto, answering your question, yes. Very good question, because that is the, the complication that everybody fears the most. Overall, it's a very, very rare complication, which I mean by means of very rare is it's less than 0.1% or even less than 0.1%. But the issue is that it's an immediate complication, and an immediate complication that requires to be watched at least, and usually it will settle down. My suggestion to avoid complications of any sort of, especially the neurological complication, is to switch over to a physiological gas. That's your best bet to have and avoid any neurological complication. And of course, as been shown, that neurological complications are due to now have been attributed to endothelin release as well as histamine release. So keep those anti-endothelin and antihistamines ready just in case you find that the complications are not getting over in about the usual 5 or 10 minutes. Thank you very much.
Thank you so much, Malay, and thank you so much, Professor Intriago. We are coming to the end, so we have the closing greetings of Professor Takashi Yamaki on behalf of all the GSP.
Thank you for participating in the 40th annual meeting of the Japanese Society of Phlebology. And I'd like to thank the Buenos Foundation for their full cooperation in hosting the international session. Their presentations are all educational and informative and were useful for daily practice.
Switch off the mics.
We have been organizing the international sessions for the past 2 years at the annual meetings and were successful. We are now connected from the continent to continent each other, and we are truly believe that the international session is becoming one of the leading scientific sessions on phlebology in the world. The next annual meeting of the Japanese Society of Phlebology will be held from June 10th to 11th at Hanamaki Hot Springs. We are not quite sure if the coronavirus epidemic has ended by that time, but at least we believe that we can enjoy the next year's international session as usual. Thank you again. See you next year.
So thank Professor Yamaki. We ask Khaled to shut down all the mics, please. Shutting down the mics. And we are going to finish with some considerations. Khaled, can you please switch off the mics, Khaled? Thank you. So we'd like to conclude with some final consideration. This is a virtually long trip we made above all the oceans. I do truly believe that oceans and also this COVID time can separate continents, but not our venous and lymphatic zones. So it has been truly a pleasure to being all together virtually in Japan. A deeply thank goes to particularly the Latin America friends who have been with us until so late in the night. I think it is very important to gather together to promote an evidence-based global interaction for venous and lymphatic advancement for both our patients and of course our personal knowledge as professionals. I'd like to take this chance to deeply thank on behalf of all the VWIN Foundation, all the Japanese colleagues who have joined the global effort we made in 2019 during the VWinter meeting, publishing a document that I invite you to read about similarities and controversies in global guidelines, it's pretty interesting that we have the same body of literature in phlebology and also in lymphology, but we give different recommendations around the world. So it's really important we analyze these differences. Of course, we will have to keep the different scenarios for the different countries, but it's also important to have a homogeneous data analysis, I think. It is also important to always propose evidence-based data to both colleagues and also patients. We have been quite astonished by this paper showing that up to 40% of the medical websites are including fake news. I'm sure this is a problem in all our countries. These 40% websites are actually shared in average 450,000 times. So for this reason, the next project of BWIN will be in Dubai. I deeply thank all the societies already involved in this group effort. I invite you to visit this webpage where you can report also in Japanese eventually encountered fake news in the venous lymphatic field, from inadequate commercials, for example, or inadequate attitudes. It's really important. I think we report them. We are working on a consensus document involving all these colleagues from all around the world. And again, I deeply thank all the ones involved in this group effort, as I deeply thank the Panamerican Society, the Latin America Venous Forum, and in particular also Chris Ragg for having provided all of them the awards to the abstracts. All the abstracts you have enjoyed today are winners, so congratulations to all. They will choose attendance in these different meetings around the world. So Ecuador in 2021, Argentina in 2021. There is a wonderful masterclass held by Professor Ragg in Berlin that will start as soon as the COVID pandemic is over, and then in 2022 in Dubai. But not before having enjoyed the next initiative that will be this Saturday, connecting this time Latin America and Africa. So I really invite you, of course, from Japan. It will be impossible at 3 a.m., but everything is also recorded as this session. So the webinar will be in the VWIN Foundation webpage, and you can enjoy that and also get your Latin American and African certificate. I'd like to conclude once again societies, including also the French Society of Phlebology, for joining us. I like to remind everybody, also the ones who will watch this video in the recorded form, that it is possible to request the certificate of attendance if you watch that in the platform. And I deeply thank once again all the Latin America friends represented here by Lorena Grillo for being with us. I see Luis is still with us at such a late hour in the night, maybe because we really created bridges that are talking about friendship and also scientific advancement, as these precious memories I really treasure, and for which I deeply thank the GSP, as I deeply thank Amy for the wonderful job she did in putting this session together with Professor Mo and Professor Takashi. I invite you at in 20 minutes from now to join us for another GSP session dedicated about disaster, venous disease, and guidelines. And I like to conclude giving the mic to some of the Japanese friends who are here. I see that we have Professor Mo, I see we have Professor Takayiro, so I think the final word should go to our honorable host of this precious initiative, and I deeply thank the Japanese Society for this initiative. Mo or Takayiro, would you like to conclude? Unmute yourself. Takayiro or Mo?
Yes, Takahiro. Yes, so final word from JSP. Thank you very much for organizing everything. And I'm working, but actually Takahiro work a lot. So final word is from Dr. Takahiro Imai. Yes.
Thank you very much for today. See you next time. I would like to seeing you over the world again. Thank you.
Thank you, Takayiro. So I remind everybody that there is a second link we sent by email. If you want to join us, we have 20 minutes break, and then we will have a session about disaster guidelines and venous disease, always at the JSP. Thank you so much, everybody. Thank you. Bye.